Welcome back. My name is Paul Westings and I'm your host. This is the third training video in the series entitled The Echocardiography Survival Kit. The last video dealt with LVF, or left ventricular function. We hope you enjoyed it. In today's video, Tommy will teach you how echocardiography can be used to diagnose valvular heart disease. Have fun. Oh, before I forget, you can always go back and re-watch the videos we sent you so far. All you need to do is pull up the mail with the link to the specific video, then click on the link again.
Welcome back to the Echo Survival Kit. This is part 3, in which we will be dealing with the heart valves. Before I get started with the valves, a short review of what we did last time. I explained how the heart contracts and that there are several components of contraction: radial, circumferential, and longitudinal. Radial contraction contributes most to ejection of blood, while longitudinal dysfunction is often an early sign of left ventricular impairment. When you look at the left ventricle, take a look at its shape, its size, and its function. I explained that there are different shapes that the ventricle can have: the shape of a bullet in normal hearts, round in dilated cardiomyopathy, outpouched at the apex in patients who have an aneurysm, the shape of spades in apical hypertrophic cardiomyopathy, and the shape of a banana in other forms of hypertrophic cardiomyopathy. You can estimate the size of the left ventricle by comparing it with the right. It should be 1/3 larger. But in addition, you can measure the size of the left ventricle simply by using a diameter measurement. Remember, the upper limit is somewhere between 55 to 60 millimeters, depending on the body surface area. When looking at left ventricular function, I talked about the importance of eyeballing, and there you will have to look at inward motion of the endocardium, myocardial thickening, and the motion of the mitral annular plane. I gave you some examples and showed you how I would quantify these left ventricles, ranging from hyperdynamic to severely reduced. I strongly emphasized that there is a relationship between the size and the function of the left ventricle, and that you tend to overestimate left ventricular function in small ventricles. I talked about the pitfalls, as just mentioned, in small ventricles, but also the problem of tachycardia, arrhythmias, and left bundle branch block. Then I explained what M-mode is and showed you that it can be used to look at the motion of the mitral annular plane, which can be helpful to look at longitudinal function of the left ventricle and to assess left ventricular function. If you want to look at some of these issues in more detail, go back to your old email. You will have access to the previous lectures. Now, we have to move on.
In the 60s and partially also in the 70s, the diagnosis of valvular heart disease was mainly based on the physical exam, the ECG, the phonocardiogram, and things like chest X-ray. And heart catheter was usually only used to confirm the diagnosis or to see how severe it actually was. With echo, this has changed completely. Phono is simply not used anymore. The physical exam is more a screening modality, and heart cath plays practically no place in the primary diagnosis of valvular heart disease anymore. So echo has really changed a lot. In this tutorial, you will see how fast and simple it can be to see if something is wrong with the valve. When you study heart valves, you will need to understand the hemodynamic consequences of the individual defects. In our masterclass, we focus on such things and show you how this information can also be used to determine what to do with the patient once you found such a defect.
Sure, valvular heart disease can be a very complex issue, especially if you consider that we have 4 heart valves, and they can all be stenotic and incompetent. And then they also influence each other. So I will have to focus on what is common and kind of sneak in the rest.
The 2 most common valvular defects are aortic stenosis and mitral regurgitation. Aortic stenosis is now the third most common cardiovascular disease following coronary artery disease and hypertension. Mitral regurgitation is also a common disease. Just think of mitral valve prolapse. And both valvular defects can easily be detected with echo. There's only one prerequisite. You first have to be able to see the valve and be able to image the valve.
Here are just two examples that show you how clearly we can visualize the heart valves with echocardiography. Here we see the aortic valve with the three cusps. This is the pulmonic valve. Here we have the tricuspid valve, while we have the aortic valve here and the mitral valve here. Fantastic image quality, but to tell you the truth, those are my favorite echo loops. In everyday clinical practice, especially if you image obese or elderly patients, your image quality will look more like this. But you can still see the aortic valve, the pulmonic valve, and the mitral valve. So even though the image quality is not so bright, you will still be able to make a diagnosis in most cases. Here is another image with very poor image quality. The question will be, is something wrong with this echo or not? Is everything okay with the valves? Well, I'm not going to give you the answer right away. I want you to complete the lecture, and I'll tell you at the end. After all, I want to check if you're really in the classroom or not.
But before we turn to diseases of the valve, we first need to recognize the typical features of a normal valve. First, the aortic valve.
What you see here is a special heart model which allows us to look right into the heart and also at the heart valves. What you can see here is the aortic valve, which is not completely normal because if you look closely, there are sclerotic plaques here actually on the cusps. We have the acoronary cusp here, the right coronary cusp, and the left coronary cusp. Note how thin the valve actually is and how coaptation between the cusps occurs during diastole. In a close-up view, you can even appreciate the little nodules which are located on the tips of the cusp. At the beginning of this lecture, I showed you that these details can also be visualized with echo. What you see here is a 3D reconstruction, a technique which is now more and more used also in the assessment of valvular heart disease. This, however, will not be the topic of this course, maybe sometime in the future. To see the aortic valve, we have to go back to the basics, and I will now have to teach you another view, a view we haven't seen so far. Do you remember from the first part of the echo survival kit when I talked about how to image and I showed you the peristernal long axis view? In this view, you are able to see the aortic valve. The only problem is we cannot see all cusps. To do this, we have to use a view which is called the peristernal short axis view. Basically, this view is orthogonal to the view I just showed you, and then you are cutting right through the base of the heart where the aorta is the central structure. The following demonstration will show you exactly what I mean.
The peristernal short axis is in a 90-degree orientation to the long axis. So if you remember how we had the long axis, the marker was pointing towards the right shoulder. Now what we have to do is we have to rotate the transducer clockwise until we are perpendicular to the original plane. Now the marker, which is here where my finger is pointing towards the left shoulder, or armpit actually. We can cut the short axis at different levels. This would be the level of the basis of the heart, where we can see the aortic valve. We can see, this is the aortic valve, we can see the left atrium, in this case with left atrial appendage, the interatrial septum, the right atrium, the tricuspid valve, the right ventricle, and the right ventricular outflow tract with the pulmonic valve. We can also see certain details. For example, here, it is possible to even see the origin of the right coronary artery. The left coronary artery is more difficult to visualize in a short axis view. It would be somewhere down here.
For review purposes, again my favorite loop, with the aortic valve in the center, left atrium, interatrial septum, right atrium, tricuspid valve, right ventricle with the right ventricular outflow tract, the pulmonic valve, and the pulmonary artery. For all of you who want to be real geeks with respect to the aortic valve, how can you name the different cusps? Well, the right coronary cusp is always close to the right ventricle. The left coronary cusp always close to the pulmonic valve, while the acoronary cusp is always close to the intraatrial septum. We're not yet done with the new views that I want to show you in this lecture, because there's another view which helps us to see the aortic valve, and this is the 5-chamber view. Again, we need an apical position, and from here we image upwards, very similar to the way we do it with the 4-chamber view, only that we're now cutting through the aortic valve. The aortic valve can then be seen right here on the image. This would be the left ventricular outflow tract, which is the 5th chamber. This is also the reason this view is called 5-chamber view. To get to the 5-chamber view, we start out with a 4-chamber view and then just tilt more ventrally to cut through the aortic valve and the aorta. This is what you then see on the image. Here is the aortic valve. It will not be possible from the 5-chamber view to really differentiate between the different cusps. All you will see is the valve moving back and forth.
You come to the 5-chamber view from the 4-chamber view by simply tilting the transducer and getting more shallow towards the ventral portion of the chest. So this motion brings you to the 5-chamber view. What do you see in the 5-chamber view? You see the LVOT and the aortic valve. You don't see the mitral valve as well anymore. The left atrium is not in its maximal dimension, so it's also no view where you would really look at the left atrium.
After the 5-chamber view, here is the last view that I want to show you in this lecture. The apical long axis view. It is very similar to the peristernal long axis view, only that we are now imaging from the apex. Similar to the peristernal long axis view, we have an orientation which cuts the heart along its long axis. Thereby, we are also cutting through the aorta and the aortic valve, which can be seen here. Here is the typical apical long axis view, again in my favorite patient. The aortic valve is right down here. This is the mitral valve. Notice the close proximity between the anterior mitral valve leaflet and the aortic valve. And this is the left ventricle, and here the left atrium.
Now I'll show you how to get from the 2-chamber view to the 3-chamber view. So let's start out with the 2-chamber view. All you have to do is you have to rotate counterclockwise even further. The difficulty here is that you will have to switch your grip basically of the transducer very often, and to assure that you stay on axis, I always use my little finger to just assure that you're still in the same position. So when you rotate from the 2-chamber to the apical long axis view, you have to rotate until you finally see the LVOT and the aortic valve. Once you see those structures, you're there. What can you appreciate? First, you appreciate the septum, the anterior septum. You have the posterior lateral wall, the left atrium, and you have the posterior mitral valve leaflet and the anterior mitral valve leaflet.
Similar to the watchtower of the Chinese wall, and as a matter of fact of all watchtowers, it's important to have a view to all sides. And this is also important when you look at the aortic valve. Therefore, you should appreciate the aortic valve with more than one view. You should use the peristernal long axis view, the peristernal short axis view, the 5-chamber view, and the apical long axis view. This is also the reason I added all these views to the lecture on valvular heart disease. After this short backdrop to the basics of echocardiography, finally we will come to pathologies again, to aortic stenosis. Aortic stenosis is a disease that you will find very, very frequently. It's a disease which is on the rise simply because we have an aging population and because aortic stenosis is a disease of the elderly. You can see this very nicely here on this graph. In patients 85 years of age, 4% will have significant aortic stenosis. The hallmark of aortic stenosis is certainly the calcified valve. In addition, you will find a reduction in the aortic valve opening and motion. But this is not always the case, as you will later see. Let's study a few aortic valves. Does this patient have aortic valve stenosis? Take a few seconds to look at the morphology of the aortic valve, to see if there is calcification, and to observe the motion of the cusps. Well, I'm sure this was an easy case for you because, again, this is my favorite patient. You seem to be knowing him by now. And we have normal opening of the aortic valve and there's certainly no calcification. Next case. What about this valve? Is there calcification? Does the valve open normally? And can you estimate the severity if there is stenosis? I think we all agree that this is not a normal valve and that there is some degree of aortic stenosis. And honestly, I probably thought it was moderate, but it turned out that aortic stenosis was severe. So we can diagnose the presence or absence of aortic stenosis, in most cases at least. However, the 2D morphology only gives us a rough estimate of the true severity of aortic stenosis. Next case. What about this valve? Do you see calcification? How does the valve open? I believe there is just a bit of calcification. It's more that the surfaces of the valve are thickened, but there is a bit of reduced opening. Is aortic stenosis present? Well, probably, but very unlikely that it is severe. And it turned out that aortic stenosis was only mild. I will show you later how we quantify aortic stenosis. But for comparison purposes, here's my favorite patient again. Look how the valve opens here and compare it to the valve here. In the normal patient, we have almost complete opening where the cusps almost touch the aortic root, while this is not the case here. Are you ready for one more? This is the valve I would like to show you. Calcification, opening motion. Well, what do you think? Some of you will probably notice that I was fooling you here because this patient does not have aortic stenosis, but he does not have a normal valve. As a matter of fact, he does not even have his own valve. He has an aortic valve prosthesis. So do you see how important it can be to have the patient history available? Usually it's not so difficult to really recognize a mechanical valve, but it can be very difficult to distinguish a normal valve from a bioprosthetic valve. I told you that morphology helps, but that there are certain things that one must also consider. So far we only looked at tricuspid valves, but the majority of patients who have aortic stenosis have bicuspid valves, and there we have to be especially careful. Why? Well, because bicuspid valves can be stenotic without being calcified. Here's an example of a bicuspid valve. You see only two cusps. This is the classic bicuspid valve. Here's another example. Take a look at the valve morphology. Aside from the fact that it too is bicuspid, there's practically no calcification. Still, the opening area is reduced. In this case, aortic stenosis was only mild. One more issue related to the morphology of the aortic valve. What happens if we cannot get a peristernal short axis view? Can we use the apical views, specifically the 5-chamber view? You can, however, you must consider that the aortic valve looks usually more calcified in an apical view. This has to do with the fact that we're hitting the valve parallel and therefore there's more reflection and the valve appears brighter. Constantly throughout the presentation, I'm talking about quantification of aortic stenosis. but I haven't shown you how to do it. Now is the time. Do you remember this video clip from the first part of the Echo Survival course? I told you I will explain what this video has to do with valvular heart disease, hemodynamics, and specifically with this man here on the left. Well, the reason the water is shooting out like crazy from this tubing is because the tubing represents a narrowing. And if water comes to a narrowing, it increases its speed. And Bernoulli was the one who explained the relationship between the speed and the pressure gradient, the gradient before and after the stenosis. Bernoulli's original formula to calculate the pressure gradients was fairly complex. In echocardiography, we use an abbreviated version, which works very nicely. This is the formula. Velocity squared times 4. Very simple. This is the only formula you need to know in this course, and it is by far the most important formula in echocardiography. Watch how this formula can be used to quantify aortic stenosis.
To quantify aortic stenosis with CV Doppler, I would start from the apical approach. And I would try to get an apical 5-chamber view and place the continuous wave Doppler spectrum right inside the valve. Now, it's very important to also put the focus point exactly where the valve is. Now you can see the spectrum here is not very good, so you can optimize the signal by moving your transducer further lateral, and then you have a much better angle to the ultrasound beam and you are really parallel. And this way you will usually get much higher gradients than if you use the classical 5-chamber view. And in this case you also get a much better spectrum. So from this position I would then wait to see if I get a beat which is high, and then I could measure the gradients. Also very important to see that you get the LVOT within the curve. First of all, this gives you information if you really have the signal of the aortic valve, and second of all, it's usually a sign that you are in an optimal position with your Doppler spectrum.
So once you have such a signal, all you need to do is take the cursor, put it at the tip of this curve, thereby measure the maximum velocity, which in this case is 5 meters per second, and the machine will automatically calculate the maximal gradient by applying the Bernoulli equation. But you can also do it in your head. 5 times 5, in other words, 5 squared is 25. You multiply that by 4, and what do you get? 100. 100 is the peak gradient. So the machine was correct. What does this mean for the ventricle and for the patient? A gradient of 100 millimeters mercury means that we have a pressure drop of 100 millimeters mercury between the left ventricle and the ascending aorta, because the aortic valve is in between. Which means that if we have an arterial blood pressure of 120 millimeters mercury, the pressure in the left ventricle is 220 millimeters mercury, 100 millimeters mercury more. So a pretty big burden on the left ventricle, which explains why the left ventricle in patients with severe aortic stenosis sooner or later fails, and why patients will then become symptomatic. The only thing now left is to translate this into a grading scale. To make it easier for you, I generated this little table here. Two things that you have to remember up front. If the velocity is above 2 meters, then we speak of aortic stenosis. If the velocity is above 4 meters, then aortic stenosis is severe. Here you can read the corresponding gradients, which are nothing else than these velocities transferred with the help of the Bernoulli equation into the maximal gradients. With this information in your head, you should be able to quantify real cases. How severe does aortic stenosis appear to be in this short axis view, where we can see the morphology of the valve, and now the corresponding continuous wave aortic valve signal, where we measured a peak velocity of 2.3 meters, which amounts to a peak gradient of 22 millimeters mercury. So, aortic stenosis is mild. It's above 2 meters, but below 3 meters. Usually in clinical practice, the biggest obstacle in correctly quantifying aortic stenosis is that you're not parallel to the jet of aortic stenosis. This can happen fairly easily, simply because you do not see in which direction the jet is really going. So you're kind of blind. Therefore, you should use more transducer positions. You should play around from an apical position and see if you do get more gradients if you just twist the transducer more to the left or to the right. And there are also other techniques, windows, and views that you can use to correctly quantify aortic stenosis. This is something you will learn when you dig deeper into echocardiography.
Aortic stenosis also affects the function of the heart. So also look for left ventricular function and also for the extent of left ventricular hypertrophy.
Here's an example of a patient with severe aortic stenosis who shows all the typical secondary features of severe stenosis. Left ventricular hypertrophy, very thick myocardium, reduced left ventricular function, and an enlarged atrium. Are you ready for a little training tip? If everything fails, why not try the good old stethoscope? By using the stethoscope at the beginning in every patient, you will also improve your auscultation skills, and you will be able to get a better feel not only for the presence of aortic stenosis, but also if aortic stenosis is severe or not. However, no matter what you do, don't forget to smile just the way the nurse smiles in this little short video. In conclusion, quantification of aortic stenosis can really be challenging. But once you mastered all the technical and hemodynamic issues related to aortic stenosis, you will be king or queen. By the way, this is the crown of the Habsburg Empire. It can be found in Vienna, my hometown. But now let me turn to the second most common valvular defect, to mitral regurgitation. Significant mitral regurgitation occurs in approximately 2% of the population. Again, I want to start with a video clip showing the mitral valve in motion. This is the view from the left atrium. You can tell that we have two leaflets, an anterior leaflet and a posterior leaflet, where the anterior leaflet is longer. However, the posterior leaflet takes on more of the circumference of the mitral valve and therefore has about the same area as the anterior leaflet. Also note that the way the mitral valve closes is not that the leaflets simply touch, but that there is an area. You see how the mitral valve is bent inwards? And so the mitral valve closes along this surface. In addition, note that the mitral valve, especially the posterior leaflet, has small little cusps. We call them scallops. This video shows you the mitral valve from the other side, from the ventricular side. This is where the chordal structures attach to the mitral valve. There are a number of different chordal structures which form a fairly complex subvalvular apparatus. Many of these structures can be visualized with echocardiography. Again, here's a three-dimensional reconstruction of the mitral valve. The valve which lends itself probably the best for three-dimensional reconstructions and three-dimensional imaging with echocardiography. The issue I would like to deal with next is the question why. Why do patients have MR? What is the cause for mitral regurgitation? There are numerous different causes, but I picked the three most common causes, at least in the Western world, which are mitral valve prolapse, annular dilatation, and coronary artery disease, specifically if it is related to an inferior or posterior myocardial infarction. This is certainly important information, but when you perform echocardiography, when should you think or when should you suspect mitral regurgitation is present? Are there certain things that you should look for? Yes. First of all, if you have a strange looking valve, then the probability is high that you have some form of mitral regurgitation.
In many instances, the 2D image will already suggest the presence of mitral regurgitation. On our online course, you will find many such examples. There you will also find a complete atlas of echocardiography with all sorts of pathologies. Here are a few examples that give you a glimpse into the large variety of potential pathologies you can find on the mitral valve.
However, to detect what is strange and what is not requires that you know how the normal mitral valve looks. take a look at these two valves. Can you already determine which one is the normal valve and which one is not? Yes, this is the normal valve. You've seen the mitral valve on several images already, and you can see the anterior leaflet and the posterior leaflet and the typical motion of the valve. Look that the valve is not thickened, and then take a look at this valve. Here we have significant thickening of the mitral valve. There's abnormal motion, especially here in the posterior region of the annulus. And there's also what we call a mitral valve prolapse. We'll talk about that topic a bit later. And sure enough, the valve is incompetent. This can be seen in the color Doppler here. We'll talk a bit later on how we can discern jets with the help of color Doppler. Are you ready for some more strange looking valves? Can you find the normal and the abnormal? Now in a 4-chamber view. It's not so difficult. This is the normal one, and here you have an abnormal mitral valve. A very long posterior leaflet which prolapses into the left atrium. The valve is thickened. We also have an abnormal motion. So not difficult to tell. Again, a patient with mitral valve prolapse. There you would expect mitral regurgitation. Another one. This time an apical long axis view. The anterior leaflet, the posterior leaflet, anterior and posterior. Which one is the normal valve? Correct, this is the normal valve. Well, this valve looks strange. What really looks strange here is the posterior leaflet, because you can see the tip of the posterior leaflet below the level of the annular plane. What we have here is a flail leaflet. There is rupture of a chordae. And you can even see or appreciate the coaptation defect. And is there mitral regurgitation? Sure enough. Mitral regurgitation is not only severe, but it is very severe, as you will later understand when we come to color Doppler. A very important point I would like to make is that the morphologic abnormalities do not correlate, always at least, with the severity of mitral regurgitation. You can have very subtle defects. This is almost a defect you might miss, but still very severe mitral regurgitation. Compare this with this patient here that I showed you previously, where you have significant valve abnormalities, but in reality not so much mitral regurgitation. So morphology and MR severity don't always match. Is there anything else you can do that can help you to detect if mitral regurgitation is present? Similar to aortic stenosis, also wash your ears and use your stethoscope. I promise that I will cover the issue of mitral valve prolapse. Mitral valve prolapse has many names: myxomatous mitral valve, floppy mitral valve, classic mitral valve prolapse, or morbus Barlow, but in reality, they're all the same. I'll just be talking about mitral valve prolapse and show you the typical features that you can find in this pathology. When you look for these patients, it's very important to understand that it's a syndrome. Mitral valve prolapse does not mean that there is only one feature, namely prolapse of the leaflets. You also have thickening of the mitral valve, myxomatous thickening, of the subvalvular apparatus, and often a rocking motion of the posterior annulus. All these are parts of the mitral valve prolapse syndrome. There are fairly large variations which of these components is most prominent. In some patients, mitral valve prolapse can only be very subtle, and the other things, such as myxomatous valve thickening or rocking motion, much more prominent.
The 2D information of the mitral valve is certainly important, but it does not necessarily allow you to make the diagnosis of mitral regurgitation. What is also important is the extent of valve pathology does not necessarily correlate with the severity of mitral regurgitation. So, to detect mitral regurgitation and to determine how severe it actually is, you have to use color Doppler.
Do you remember when I explained post-wave Doppler and I showed you that there's a sample volume where you can measure the velocity and the direction of flow exactly within a certain area? Basically, this is also how color Doppler works. With the only exception, we don't only have one little sample volume, but many different sample volumes in a region of interest that we can define on the machine, and which we also call the color box. The reason we call it color box is because the flow direction and the velocity is encoded. Each little area gets a certain color. Which color it gets is defined by the so-called color map. And obviously, since we have moving images, the color within a certain area changes constantly. Even though you can adjust the color maps on the machine, and even though the color maps also vary from vendor to vendor, there is still a few common traits. Flow towards the transducer is depicted in reddish colors, while flow away from the transducer in blue. The higher the velocity gets, the lighter the colors get. And if the velocity exceeds a certain value, this value is usually shown on the top of the bar, then we will not get a distinct color, but we will get a mixture of many colors, like a mosaic. This is also called aliasing. The development of color Doppler was certainly a breakthrough in echocardiography. All of a sudden, it was possible to see the blood flow within the heart. And it was possible to see so-called jets. Jets are areas of higher velocity, which are clearly defined and which can occur, for example, in situations where you have an incompetent valve or where you have a flow acceleration because there is some form of narrowing or stenosis. Here's an example of pulmonic regurgitation. This is the pulmonic valve, and this is the jet. Take a closer look at the jet. What do we see? The first thing we see is that the main color of the jet is red, which means it's going towards the transducer. The other thing you can see is that there are areas where we have higher velocities at the center of the jet, lighter colors, and even higher velocities where we have a mixture, or in this case, a yellowish color. So with the help of color Doppler, we can not only detect jets, but also see how large they are, and semi-quantitatively at least estimate what their velocity is. I'm sure you already know why I'm showing you this: to quantify mitral regurgitation. Obviously, the size of the jet plays a role. Here are 4 different examples which show 4 different degrees of mitral regurgitation. Here on the top left is just a very little flame, a blue flame. Obviously, it has to be blue because mitral regurgitation flows towards the left atrium, which means it's away from the transducer and therefore blue. But the jet is very small. In this case, the jet is a bit larger, and even larger here, and very, very large here. Also note that there's a lot of mosaic colors in here, so the velocity is fairly high, which is typical for mitral regurgitation. So in general, the bigger the jet, the more mitral regurgitation. However, there's one component of the jet which is especially important, and this is the so-called flow convergence zone. Here's an explanation of what the flow convergence zone is. Take a look at this water plant, and specifically at the hole right here, and watch how the water flows. As the water comes towards this hole, its velocity increases, and the area of high velocity will be larger if the hole is larger. The same is true for echocardiography. If we have a regurgitant orifice right here, we also have a flow convergence zone. This is the little area here. Note how we have higher velocities right at the center and lower velocities in concentric shells further outward. And the larger this flow convergence zone is, the more blood will pass through the mitral valve and the more mitral regurgitation will be present. So always look at the size of this flow convergence zone. Now an example with an even larger flow convergence zone and one with a very large flow convergence zone. So the size can help you to quantify mitral regurgitation, and it is sometimes better than looking at just the pure size of the mitral regurgitant jet. So specifically focus on the proximal portions of the jet. If you cannot see it, or if it is only very small, you can be sure that mitral regurgitation is only mild. What else is important for the quantification of mitral regurgitation? Eccentricity. If a jet is very eccentric, and if it impinges on a wall, it appears smaller than it in reality is. We will underestimate the severity of mitral regurgitation. Machine settings. If we choose a gain setting which is too high, the jet will appear larger, and we will overestimate the severity of mitral regurgitation. The geometry of the jet, especially if we only look at mitral regurgitation in one view, which you should not do. Multiple jets, you have to add them together basically. And finally, image quality, especially image quality, because if you cannot visualize a jet, we will not detect mitral regurgitation at all, or we will severely underestimate it. Putting all this information together, are you ready for a little game? Sort these echoes according to their severity from A to D. B, C, A, and D. In B, we hardly see a jet, and there is no flow convergence zone. Regurgitation is trivial. In C, we see a jet, which is a bit larger, and there is a small flow convergence zone. MR is mild. In A, a flow convergence zone is clearly visible. The jet is relatively large. It is moderate. And finally, in D, very large flow convergence zone and a very large jet. Regurgitation is severe. Now, after this little detour, which showed you how to quantify mitral regurgitation, let's go back to our suspects. We talked about abnormal valve morphology already. Now, I want to show you how a dilated left ventricle can point to the presence of mitral regurgitation. Here is what I mean. Take a look at this left ventricle. Can you see that the ventricle is dilated? You can if you measure it. It's 62 millimeters. But in addition to the dilated left ventricular function is also normal or even hyperdynamic. The combination of a dilated left ventricle, which is hyperdynamic, often points to the presence of volume overload. Volume overload, which can be caused by mitral regurgitation. Oh yeah, and by the way, you see the left atrium? It too is enlarged. This can also be a sign of mitral regurgitation. And truly, there is mitral regurgitation. Very severe regurgitation, as a matter of fact. By dilating, the left ventricle adapts. It adapts to the condition that it has to pump more blood because part of the blood goes back to the left atrium. However, you should be aware that the size of the left ventricle not always correlates with the severity of mitral regurgitation. To illustrate that, I will show you two examples. First, a patient who has a moderately maybe dilated left ventricle, but very, very severe mitral regurgitation. And here, a patient with a very large ventricle, but only mild mitral regurgitation. What is the difference between the two with respect to the cause of mitral regurgitation? The first case had primary mitral regurgitation following endocarditis. The second patient had functional or secondary mitral regurgitation because he has dilated cardiomyopathy and because the mitral annulus is simply dilated. There are also other causes for a dilated left ventricle. Mitral regurgitation can cause left ventricular dilatation, but in turn, a dilated left ventricle can also cause mitral regurgitation. So sometimes we have the so-called hen-egg dilemma where we do not know what came first, regurgitation or dilatation. There is one more suspect we need to talk about, and that is inferior or posterior myocardial infarction and coronary artery disease. Why is that associated with mitral regurgitation? Because the infarct causes distortion of the left ventricle, which in turn affects the subvalvular apparatus. What happens very commonly in inferior myocardial infarction is that the posterolateral papillary muscle is positioned outwards because there is an infarct. And therefore, we have restriction of the leaflets, which then can cause incompetence of the valve. So basically, the structure of the valve is okay. However, distortion of the ventricle causes distortion of the mitral valve, and therefore incompetence. Here is a beautiful example of what I just showed you. This patient had a posterolateral infarct. By the way, you will hear more on infarcts in the fourth and last part of the echo survival course. But what you can see here is that the mitral valve is distorted and restricted. What does that mean? The posterior leaflet simply does not move anymore. It is tethered in a way to the papillary muscle. And since the mitral valve cannot close or cannot coapt, we have significant mitral regurgitation. By the way, how severe do you think mitral regurgitation is? You should know by now. It is very severe in this case. One last example so that you recognize the pattern the next time you see it. Patient with posterolateral infarct, restricted posterior leaflet, you can see that even better here in the detailed view. Coaptation defect with significant mitral regurgitation. So this concludes the most common forms of mitral regurgitation, at least in my part of the world. I'm well aware that this is different somewhere else. Therefore, you will also see some more cases and some other causes in the fourth and last part of this echo survival course. So this basically concludes this lecture. Oh yeah, there's one more thing. Remember I showed you this aortic valve and I asked, is there something wrong with it? I'm sure you all recognized. It is calcified, thickened, and the patient has moderate aortic stenosis. So I hope you enjoyed this chapter on heart valves, and I hope you will check your inbox for the fourth and last part of the echo survival kit, entitled Bits and Pieces.